Hi everyone, my name is Eden Claire Celestra and my teaching strategy is basically a lecture using some visual aids to enhance understanding and retention of information. Today, I will be talking about the CTG or the cardiotocography. Learning objectives is that by the end of this presentation, the students will be able to define CTG, enlist the purpose of using CTG, explain the methods for performing CTG, differentiate internal and external CTG, interpret tracings, describe the significance of the procedure, and enumerate the reasons to monitor the baby's heart rate. And now we are going to define the cardiotocography. It is a technical means of recording, graphy, the fetal heartbeat, cardio, and the uterine contractions, toco, during pregnancy. It is typically done in the third trimester. The machine used to perform the monitoring is called a cardiotocograph, more commonly known as an electronic fetal monitor. CTG can be used to identify signs of fetal distress. Simultaneous recordings are performed by two separate transducers, one for the measurement of the fetal heart rate and a second one for the uterine contractions. Transducers may be either external and or internal. External measurement means trapping the two transducers called the tackle dynamometer, TOCO, measures the tension of the maternal abdominal wall, an indirect measure of the intrauterine pressure, which is the contraction, and a fetal heart rate transducer, which measures the fetal heart rate. And this is an example of an external fetal monitor. In using the internal monitoring, we also use the pressure-sensitive transducer, the TOCO, to measure the intrauterine pressure, while we use a fetal scalp electrode, which is a small circular corkscrew-shaped needle attached to a coated wire. The clip is covered with a long, protective, flexible plastic covering and guided up through the mother's vagina by the caregiver doing an internal examination. The needle is gently rotated into the skin on the baby's scalp. Once the clip is attached, the plastic cover is removed, leaving just the wire. And this is an example of an internal monitor. As I have previously mentioned, we have two methods. We have the external EFM, which is the most commonly used, and we have the internal EFM. In the internal EFM, the fetal scalp clip has two colored wires attached. The wires are connected to the lead with a small conducting device strapped to the woman's thigh. The lead is then plugged into the monitor, and a typical CTG reading is printed on paper and stored on a computer for later reference. The use of CTG and a computer network allows continual remote surveillance. A single nurse, midwife, or physician can watch the CTG traces of multiple patients simultaneously via a computer station. This procedure should not be any more uncomfortable than a normal vaginal examination. The internal electrode monitors the baby's heart rate more accurately than an external Doppler. Also, internal measurement requires a certain degree of cervical dilatation, and the waters need to be broken to attach the fetal scalp electrode to the baby's head. If they are not already broken, this will need to be done to allow the electrode to be attached. And women who carry the herpes, hepatitis B or C, or HIV viruses are recommended not to have internal monitoring because it can increase the baby's chances of becoming infected with these viruses. Let's go to the CTG interpretation. This is an example of a CTG tracing, wherein we can see that the red trace is for the fetal heart rate and the blue trace is for the uterine contractions. As I have already mentioned, cardiotocography is used to monitor several different measures. We have the uterine contraction, which are quantified as the number of contractions present in a 10-minute period and average over 30 minutes. Normal will be less than or equal to 5 contractions in 10 minutes, and high would be greater than or equal to 5 contractions in 10 minutes. We also have the 4 fetal heart rate features, which are the baseline heart rate, which is the average baseline fetal heart rate. Reassuring feature will be 110 to 160 beats per minute. Non-reassuring feature is 100 to 109 BPM or 161 to 180 BPM. Abnormal feature would be less than 100 BPM, which is the fetal bradycardia, or greater than 180 BPM, which is the fetal tachycardia. We also have the variability. These are fluctuations in the fetal heart rate. This causes the tracing to appear as a jagged rather than a smooth line. Variability is indicative of a mature fetal neurologic system and is seen as a measure of fetal reserve. Reassuring feature is greater than or equal to 5 BPM. Non-reassuring feature is less than 5 BPM for 40 minutes but less than 90 minutes. Abnormal feature is less than 5 BPM for 90 minutes. Decreased variability may occur in the following situations. We have hypoxia and acidosis, narcotics and anesthetic agents because these depress the fetal nervous system. Usually variability increases as the drug is eliminated from the baby. We also have due to prematurity and maybe the fetus is sleeping. Next we have accelerations. These are an increase in fetal heart rate from the baseline by at least 15 beats per minute, lasting for at least 15 seconds and should be 2 accelerations every 20 minutes, lasting no longer than 2 minutes. Our reassuring feature is if it's present, and in labor, the absence of acceleration with an otherwise normal CTG is of uncertain significance. We also have the decelerations. These are a decrease in the fetal heart rate from the baseline by at least 15 beats per minute, lasting for at least 15 seconds. There are 3 types of deceleration depending on the relationship with uterine contraction. First, we have the early deceleration, which begins at the start of the uterine contraction and ends with the conclusion of the contraction. This is a mirror image. This is due to an increased vagal tone because of the fetal head compression. We also have variable deceleration, which occurs anytime irrespective of uterine contractions due to an umbilical cord compression. Also, late deceleration, which begins at or after the peak of a contraction and ends long after, hence the late when compared to early decelerations. This might be due to fetal hypoxia, a uteroplacental insufficiency, which is the most worrisome deceleration. Now, I'm going to show you examples of a CTG tracing. This is a trace with a normal variability. And this one has reduced variability. This one has variable decelerations. This is another trace that emphasizes the accelerations. This is your sinusoidal pattern. And this one has prolonged deceleration. For the significance, we can say that it's a normal trace when it has a baseline rate of 110 to 160 beats per minute. It has a normal variability, the absence of decelerations, and accelerations may or may not be present. We can say that it's a suspicious trace when the tracing is with one non-reassuring feature and the other 3 are reassuring. It's also not predictive of abnormal fetal acid-base status, but evaluation and continued surveillance and re-evaluation are indicated. We can say that it's a pathological trace when the tracing is with 2 or more non-reassuring feature or 1 or more abnormal feature. It predicts abnormal fetal acid-base status, and this requires prompt evaluation and management. Reasons to monitor the baby's heart rate can include If there are health concerns for the mother during late pregnancy, we have bleeding, high blood pressure, premature labor, diabetes, and cholestasis. Also, if there are health concerns for the baby, like those small for dates or abnormality of the baby, and if the pregnancy is overdue. Also, as a routine procedure during labor, some delivery suites have a policy to perform a routine 20-minute recording of the baby's heart rate when the woman arrives in labor. Next, if the waters break and the labor has not started. If the woman is waiting for her labor to start with ruptured membranes, the caregiver may perform a 20-minute trace to check her baby's well being. We also have if the baby is showing signs of distress, if the baby's heart rate is noticed to be lower when the caregiver is listening intermittently, usually after a contraction during labor, or if the waters break and there is meconium staining of the amniotic fluid. Next, if the labor is being induced or augmented with an oxytocin drip or prostaglandins. These medications have the potential to overstimulate the uterus and distress the baby. Lastly, if the woman is having an epidural for pain relief in labor. The baby's heart rate can lower in response to a fall in the woman's blood pressure as a possible side effect of an epidural. And that would be all for today's video. Thank you so much for watching. I hope you have learned something from me. See ya! Bye-bye!